are, but with all due respect to everyone that's here on time, we'll go ahead and get started. So my name is Jill Rockfeisel, the chair of the Department of Psychiatry, and I want to welcome everyone to our Grand Round series, faculty, trainees, and individuals from other departments. We really enjoy having a wide audience. So thank you for joining us. Just want to remind folks, although I think I just learned that people are automatically muted now, and so you can't unmute yourself right now. However, we have the chat being monitored for questions, and we will take them, in order as they come in when we're ready for questions. So I just want to highlight that this is our 8th annual Telemental Health Grand Rounds. This is truly very timely, given that this is a time where finally the healthcare community has recognized 3 really important things. That A, there's a huge demand for mental care, and it's very, very important. The second is there's a need to enhance access to care, and there certainly is a need to focus on customer satisfaction, and certainly telemental health does all 3 of those things. So I would like to hand over the virtual podium to Rob White, who is going to do a more detailed welcoming and introduction. Rob?
Okay, thanks, Jill. Mm-hmm. Welcome, everybody. This is our 8th annual Telemental Health Grand Rounds. The title is The Current Telemental Health Landscape, a National and Local Perspective. And before I get into that, I want to just acknowledge our team members for Telemental Health. First of all, our IT team, who make sure that we're on. And, David Flax is the director. Andre Jackson is our support. I also want to acknowledge Annie, who is the coordinator that pulled together this event. Thank you, Anna. And our director of Telemental Health is Kelly Coble. Medical director is Dr. Patrick Young. Our senior medical advisor is Dr. David Pruitt. The division director for addiction is Eric Weintraub. The child division director is Dr. Sarah Edwards, and the senior administrator, Afshan Qureshi. And they're all part of the team that put together these many projects that we've had over the years for telemental health. And we're very pleased today to have one of the leading legal minds in telemedicine with us. She comes from the sunny state of Florida, and as such, her name is Sunny Levine. She is a healthcare lawyer with Foley and Lardner LLP and a member of the firm's telemedicine, digital health, and healthcare industry team, working with hospitals and health systems, physician practice groups, and technology companies across the country. Sunny's practice focuses on federal and state regulatory compliance and business issues in the healthcare industry. She is a co-chair in the firm's behavioral health industry team, and she's a member of the American Telemedicine Association, serving on the ATA's Telemental Health Special Interest Group. So without further ado, Sunny Levine.
Thank you, Robert, and thank you all for joining me today for this webinar. Thank you to the University of Maryland School of Medicine, the Department of Psychiatry for inviting me to present at your 8th annual Telemental Grand Rounds. As Robert mentioned, my name is Sunny Levine. I'm an attorney at the law firm of Foley and Lardner in Tampa, Florida. My practice focuses on healthcare regulatory compliance issues with a focus on telehealth compliance and particularly for behavioral health providers. I'm very happy to present on this very important topic today, the current telemental health landscape from both a national and a local perspective. To start with, I am an attorney, and so we have to go through a bit of legal disclaimers. This webinar should not be construed as legal advice on any specific fact or issue. The contents are for general information and educational purposes only. The information on the webinar is not to be create a formal attorney-client relationship, but again, these are the personal views of myself as the author and do not necessarily reflect the views of others such as Foley and Lardner. Now that that is over, we can get started. We have a lot of material to cover today. We have set out 3 learning objectives for this grand rounds. The first is to recognize the previous legal and regulatory framework for telemental health in the US and in Maryland in particular, and challenges that relate to same. The second is to understand the benefits telehealth provides to the traditional telemental health treatment system, including the specific impacts on substance use disorder treatment. Third is to identify the regulatory changes and impacts that COVID-19 has had on the telemental health system on both the national and then also on the state level. To bring this quite personal, I just was diagnosed with or tested positive for COVID on Monday. So bear with me if there's any issues with my stuffiness or my cold. As we all know now, it is a highly contagious disease, and hopefully we are nearing the end of it, because I do not wish this on anyone. But to get started on the previous framework and the legal and regulatory framework that dictates the telemental health system. By way of background, there are significant legal and regulatory hurdles that providers are required to navigate when offering behavioral health services via telehealth. Healthcare generally is a tangled web of both federal and state laws. Then state licensing boards add an additional layer of regulatory guidance and rules and regulations. And then beyond that, there's a category of guidance called sub-regulatory guidance that boards issue that generally is not binding, but often creates an interpretive decision that should be followed for providers. When offering telehealth services, mental health or otherwise, providers must comply with both federal and state requirements, which often conflict and are very rarely consistent. So the first initial crucial component of a telehealth offering is ensuring licensure and credentialing issues. So providers, physicians, nurse practitioners, psychologists, mental health counselors, etc., the individuals actually providing the healthcare services. One of the most initial important steps that often presents a logical challenge for providing telehealth services is to ensure that all providers are properly licensed and credentialed. Before a physician or other provider can offer services via telehealth or in person, the general rule and one of the foundational issues is that the physician or provider must be licensed in the state that the patient is physically located at the time of the telemedicine consultation. So for example, if a patient is located in Maryland at the time of the telemedicine consultation, the physician providing care must also be licensed in Maryland. This does not mean that the physician needs to be physically located in Maryland at the time of the consultation, but for licensing laws, the physician must be licensed to practice medicine in that state that the patient is located in. So in our example, in Maryland. This is required under most state laws, either expressly or implicitly. We've included an example of Maryland's licensure requirements. So we see that the sources of law for this comes from 2 separate bodies. First, there's Maryland's telehealth law that is pretty clear here under the Health Occupations Code. Healthcare practitioner providing healthcare services through telehealth must be licensed, certified, or otherwise authorized by law to provide healthcare services in the state if this healthcare services are being provided to a patient located in that state. And then also the Maryland Board of Physicians, the regulations promulgated under that law, under that statute, again, provides that the individual practicing telehealth must be licensed in that state, telehealth practitioner defined below. And then also I took an excerpt from the Board of Medicine's, or Board of Physicians telehealth regulations. Does the provider need any additional licensure to provide telehealth services? For instance, in Maryland, let's say providers are already licensed in Maryland and the Board of Physicians, no, there's no additional licensure that would be required. Instead, the provider just needs to be licensed to provide services in that state, so in Maryland. Each state has their own unique licensure requirements. There is no universal license to practice medicine in every state, no special license to practice telemedicine in every state. Instead, telemedicine is just another modality of the practice of medicine. Because this is such a patchwork, this presents a significant challenge if you plan to offer telehealth services outside of the state that you're licensed in. Obtaining a state medical license can be time intensive and also very expensive. States vary on the qualifications needed for licensure, including the processing time, fees. Some states require an in-state medical examination, so some sort of special board certification within that state in order to obtain state licensure. And also, once a physician obtains that state licensure, the physician must keep up with the various state CME requirements needed to obtain that state licensure, obtain and maintain that state licensure. Again, there's very limited reciprocity between state medical boards. So if a physician is licensed in one state, that physician is not automatically authorized to practice in another state. One potential option, a potential solution for physicians is obtaining a multiple state licenses is through the Interstate Medical Licensure Compact, or the IMLC, which was created to address this legal hurdle. So the IMLC is a voluntary agreement among state medical licensing boards that allows physicians to obtain state licensure through an expedited process. If a state has enacted the IMLC, it is easier to obtain the state license in other participating IMLC states. Maryland is a member of the IMLC, so that's very helpful if you're seeking to practice telehealth in other states as a provider, because this will allow for the ability to obtain another medical license in a state that has also enacted the IMLC. So again, this is a great thing that Maryland has enacted and adopted it in 2019. And again, it gives you a leg up on your ability to obtain other state licenses if that's something that you are seeking. There's also similar licensing packs for other provider types. So for instance, there's practitioners, there's at least a nursing compact. So for RN licensure, for physical therapists, psych pack for psychologists. So there's other similar helpful licensing compacts, but again, this doesn't solve the main problem of the limited portability of licensure. It's just a way to obtain licensure a bit easier. There are other statutory exceptions that we see in many states to the need for full licensure. So notable exceptions from licensure that telehealth providers could utilize include the consultation exception. So this is a peer-to-peer consultation that's provided between providers. So kind of like a curbside consultation. State licensing laws generally permit the use of telemedicine for provider-to-provider consultations. Although this is, again, not an unlimited license and unlimited ability to provide these peer-to-peer consultations. Instead, states often limit these consultations to an infrequent or an irregular basis. So perhaps 5 consultations between another licensed clinician per year without the need to obtain state licensure to provide that peer-to-peer consultation. The next one, main one that we see, is a bordering state exception. So this allows the practice of medicine by an out-of-state physician who are licensed in a border state. A special telehealth license or registration. So certain states offer a limited license specific to telemedicine, or they implement a registration process for out-of-state telehealth providers. As I mentioned earlier, I'm in Florida, and Florida is a state that has enacted a sort of out-of-state telehealth registration process. So if you have a patient that is located or relocates to Florida from Maryland and you're not fully licensed in Florida, this would be the ability to continue the treatment of that patient through telehealth by obtaining a special registration instead of having to obtain the full license in Florida, which can take several months and is a lot more onerous of a process. And then finally, the follow-up care exception. This allows a physician to provide follow-up care to his or her patient after seeing that patient initially. So for instance, if a patient is physically in Maryland to receive some sort of in-person treatment, but then leaves to go back to their home state, let's say Florida, certain states have enacted an exception to their state licensure requirements that allows that physician who initially provided treatment to provide certain follow-up treatment related to that initial reason for seeking treatment. So post-op care via telehealth would be allowed without the physician needing to obtain a full license to practice medicine in the state that the patient relocates to. Of these exceptions, Maryland has implemented a peer-to-peer consultation exception and a border state exception. And here's the language of both. The peer-to-peer consultation exception in Maryland is pretty broadly drafted. It doesn't have a lot of the limitations that we see in other states that have enacted a similar licensure exception. It merely says that a physician licensed or residing in another jurisdiction, the physician is not considered to be practicing medicine if they're engaged in consultation with a physician licensed in the state about a particular patient and does not actually direct patient care. So again, there's no actual contact between the patient and the out-of-state unlicensed physician. Instead, it's just the licensed physician in Maryland and then the consulting physician that's not licensed in Maryland, and their ability to consult about a particular patient, but their consulting physician is not actually directing orders or any specific direct patient care. And then again, Maryland has also enacted the border state exception. As you can see, this is much more restricted than the peer-to-peer licensure exception. And so here are some of the parameters of that border state exception. So in a state adjoining Maryland, so the purposes of prescribing home health services to a patient who resides in Maryland, if the physician, and here's the two conditions, so the outside physician not licensed in Maryland would not be able to set up an office or have a regularly appointed place within the state to meet patients. And if that outside patient not licensed in Maryland has performed a previous in-person physical examination of the patient within the jurisdictional boundaries of the adjoining state. And so this is, again, another ability for a patient to continue the patient relationship without having to obtain full medical licensure. And here's just an excerpt from the Board of Physicians FAQs on telemedicine on the ability to practice telehealth without obtaining a full Maryland license. And you'll see the board provide some helpful information about that. And again, this all depends on the state of where the patient is located in. So as Maryland licensed physicians, these exceptions wouldn't apply if you seek to treat a patient in another state. Instead, we'd have to check the laws of the state that the patient is located in to see if the state has enacted a similar exception. So has the state enacted a peer-to-peer licensure exception that would allow for these types of consultations without obtaining full state licensure? Or for instance, has the state enacted a border state exception, like in Virginia, that would allow the ability to treat a patient located in Virginia without having to obtain the full Virginia medical license? So during COVID-19, the ongoing COVID-19 PHE, another exception that we generally see in state laws is an emergency exception. And recently the emergency exception has been triggered in most states due to COVID-19. Due to the widespread and rapid spread of the virus, lawmakers have demonstrated a willingness to expand access to telehealth to combat the PHE. One way to increase access to care is by waiving these state licensure requirements. We'll see that CMS was one of the first to issue this waiver on state licensure requirements for Medicaid and Medicare reimbursement issues throughout the duration of the PHE. But one thing to keep in mind, and this is a global concept, that CMS dictates payment and reimbursement. It does not impact state licenses. So CMS can't waive each state's ability to create certain licensure barriers or to require state licensure. Instead, CMS is just merely saying that they're not going to add that as a separate condition for reimbursement. So in turn, following CMS's declaration, several states have temporarily loosened license restrictions and to varying degrees have allowed, at least for a certain temporary period, out-of-state providers to use telemedicine to see patients located in their respective states. Again, states retain licensure authority. The COVID emergency waivers, they varied by state and by profession. Different types of waivers, including automatic waivers that are self-effectuating. So the healthcare provider doesn't need to take any affirmative action to practice in that state under the waiver. Other states have enacted an application process. So for instance, California has an application process where the group would fill out a form with the provider's information and submit that form. And it's essentially after that form has been submitted and accepted, the provider could provide treatment services in that state without having to obtain another type of license. And then some other states just have a contact provision. So you just need to notify the state board that you intend to provide telehealth services in that state for the PHE. Again, so these waivers vary by state. Before you plan to treat a patient in another state that you're not fully licensed in and you want to operate under one of these licensure waivers, it's important to carefully review the language of that state's waiver and follow all necessary waiver requirements. Also, and this is going to turn to our next topic, if a provider decides to practice under a state licensure waiver, the provider must follow that state's telehealth practice standards, which will go on again and later on in the presentation. And so here's a snippet from Maryland's COVID-19 licensure waiver, which is now expired, but just as an idea of how a lot of states have decided to enact these temporary licensure waivers. Here's a language actually from the licensure waiver that Maryland enacted, but again, that expired on August 15th for outside providers seeking to treat patients located in Maryland without a full license. Okay. The next section refers to telemedicine practice standards. This refers to the set of state laws and regulations governing a provider's ability to practice medicine or their profession via digital technology. As mentioned earlier, providers must abide by the state's telemedicine practice standards when providing care to a patient located in that state, either in person or via telehealth. Telemedicine practice standards refers to the state of set laws and regulations. Generally, medical practice standards are under the state's Medical Practice Act. They don't usually include specific provisions on a licensed physician's practice of medicine. So for example, you're not going to find a state law in the Medical Practice Act that says something like a physician may use a stethoscope or a physician may suture patients. Instead, these are inherent privileges that are allowed under the licensed practice of medicine that are generally permitted if they fall within the provider's scope of practice and are not expressly prohibited. But because of the use of digital technology in the practice of medicine is a relatively recent development, and some features of digital practice are only applicable to telehealth and they do not have an in-person analog, state boards of medicine have developed statutes, regulations, and issued guidance to ensure that practitioners using telemedicine are held to a high standard of care. All this centers on the protection of patients and ensuring that patients are receiving a high standard of care, as high as if it would be for traditional in-person practice. So here are some common practice standards that we see some states have enacted. All 12 of these types of practice standards, some of them have only enacted a certain subsection of these within their state laws and regulations. I'll just provide a high-level overview of some of these telemedicine practice standards that we generally see, and then we're going to circle back and see which ones Maryland has enacted in compliance with same. So number one is the modality used to establish a physician-patient relationship. So this looks to what type of communication technology, which is commonly referred to as modality, must be used to establish a physician-patient relationship via telehealth. This is the cornerstone of any medical treatment, the physician-patient relationship, again, either in person or via telehealth. The general telehealth modalities, the main ones include asynchronous interactive audio video interaction that's considered the gold standard. That's like this webinar, how you have both the audio video element to it and it's synchronous, meaning it's occurring at the same time. There's no lag in time. Another common one is called interactive audio with store and forward. So that is a interaction that utilizes extrinsic clinical information like medical records or some testing, plus an audio synchronous phone call. So it's not just a phone call, there's an additional element of some other data that is shared between the provider and patient. And then next most common one is known as asynchronous store and forward. Asynchronous store and forward is just the exchange of data and information, usually clinically relevant extrinsic information, again, like test results or medical records, that is stored by the patient and forwarded to the provider and is used by the provider in making their treatment and diagnosis of the patient. Next modality would probably be audio only, and that's the telephone only without any other data exchange between the provider and patient. And finally, remote patient monitoring or remote psychological or remote monitoring, so using some sort of extrinsic information like a data monitoring system in order to make treatment prognosis and to monitor the outputs that the patient is providing to aid in the treatment of that patient. So we often see this as a monitoring device, a glucometer, some other use of technology to assist with the provider's treatment of the patient. So again, this ties in with number 2, the modality of communication. Again, this varies from the number 1, which is what modality is used to create the provider-patient relationship. Number 2 looks more of, after that relationship has been created, what modality can be used. Some states specify that a higher modality type needs to be used to form a doctor-patient relationship. So for instance, the highest modality type of the synchronous audio-video communication. And some states differentiate that modality type from the type of technology that can be used after that relationship has been formed. So again, perhaps audio video is required to form the relationship, but after that relationship has been formed, asynchronous communication can be used, or an audio only modality can be used after that relationship has been formed. Originating site restrictions, that's the location of the patient at the time of the telehealth consultation. States have largely moved away from originating site restrictions, at least just for practice standards purposes. And this is separate from reimbursement requirements, as often we see that state Medicaid or a commercial payer may impose some sort of originating site restriction, meaning that the patient has to be located at a certain relation at the time of the telemedicine consultation for that service to be reimbursable. However, again, there's the distinction between licensing requirements and the practice standards requirements and meeting that standard of care versus reimbursement standards. So for originating site restrictions, when we're talking about telehealth practice standards, we're looking to see if the state law has any requirement as far as the patient's location to have it meet the standard of care. And most states have moved away from imposing any type of originating site restriction. 4 looks at patient site telepresenter. So does somebody need to be there with the patient, a licensed clinician or a care coordinator or nurse's aide? Does somebody need to be physically present with the patient at the time of the telemedicine consultation? And again, states also have largely gone away with the patient site telepresenter requirement except in certain specific situations like remote prescribing. It leads us into 5, which is remote prescribing non-controlled substances, and we'll discuss this in more detail later. And similar is number 6, remote prescribing of controlled substances, which we'll also move on to later on in the presentation. Medical records, providing a written summary of the telehealth visit. It's often an express requirement under state telehealth laws and rules. Even in states without that express requirement, is often a strongly recommended best practice. Practitioners must record the telemedicine consultation in the patient's medical record and must make that consult report generally available to the patient. In some states, also needs to make that report from the telehealth consultation available to the state's primary care provider. Telehealth informed consent. So many states' laws, rules, and regulations, they require a telemedicine practitioner to obtain the patient's informed consent. This is different from informed consent to treatment. Informed consent to telehealth means that the telehealth provider must inform the patient on the treatment methods and limitation of treatment associated with providing care through a telehealth platform. So this is often, you have to acknowledge and explain to the patient that there could be limitations as far as the technology, there could be technological glitches, things relating to providing care via telehealth, the risks and benefits associated with same. After the patient, you provide the patient with this information, the provider must obtain the patient's consent to provide the telehealth treatment, and these generally need to be documented in the patient's medical record. A provider must also verify the patient's identity and location. So I'm skipping ahead a bit to 10 and 11. And this, again, this is something that's different that we don't see for in-person care, because in person, there's not the challenge of having to assume who the individual is because you're in front of the individual. A majority of states have express requirements that the provider needs to identify the patient and their identity and their location at the time of each telehealth encounter. And again, this is important because the patient's location at the time of the consult is the key to determining the applicable state laws, rules, and regulations for telehealth practice and physician licensure requirements. So identifying the location of the patient and their identity is a key step in any kind of telemedicine consultation. States often don't go into detail on how a provider needs to identify the patient's identity and location, but that the provider must have some reasonable mechanism in place to do so. So even in states without an express requirement to do such, a medical board could view identifying the patient's location and identity as an essential element of meeting the standard of care. So for instance, some states we've seen a disciplinary action by the state medical board if that is not noted on the record that they have identified the patient's location and identity at the start of each telehealth consultation. Then telehealth disclosures, that refers to a provider disclosing their information, their location in general, name and board contact information to the patient at the start of the patient examination. And again, this is an element of the doctor-patient relationship. You have to let the patient know who you are, and you have to understand who the patient is prior to starting the telehealth consultation. And then 12, referrals for emergency services and or follow-up care. Some states have a requirement, express requirement, that the provider needs to provide certain emergency contact information for a resource that's physically located close to the patient in the event that the service is something that is beyond the bounds of telehealth, something that telehealth cannot accomplish. Failure to meet these 12 telehealth practice standards, or whatever the specific number that state has adopted, can lead to an adverse action, usually in the form of a board administrative complaint or other action taken against a provider's license. Usually the board will look to the overall treatment provided, to the totality of the circumstances, to see if the provider met the applicable standard of care. So usually a board won't take issue specifically with one of these practice standards. Instead, they'll look to a more holistic view of the telehealth encounter to see yes or no the provider met the applicable standard of care. Here's just a view of some of the main telehealth modalities that we discussed. Interactive audio video, asynchronous store and forward, interactive audio with store and forward, and then at the bottom, the phone only, form-based internet prescribing, or the AI type, which would be seen as the lowest type of modality type. And this is also constantly changing. So one issue that the telehealth modalities brings up, and everybody has agreed in the past at least, that the real-time audio video is the gold standard, the highest standard of care. But this also brings up issues with access. Oftentimes patients don't have access to high-speed broadband that would enable this type of interaction, this real-time interactive interaction. And instead, patients oftentimes can only utilize a phone only if that connection. And so because these state laws, at least in the past, have largely precluded the ability to provide audio-only telemedicine, at least in the initial interactions, this has provided a barrier to patients that do not have access to a higher form of technology, or more consistent technology that would allow for audio, video, synchronous communications. And so looking at this from a Maryland lens, and the sources of law in Maryland for the telehealth practice standards, we've got state law, and that's the basis of this. There's a telehealth statute under the Maryland Health Occupations Code, the physician statutes, that outlines these various telehealth practice standards. And there's also a separate subsection that's on telemental health practice standards. And then there's the state regulations promulgated under these main sections of law, including the Maryland Physician or Code of Regulations chapter on telehealth. And then also, as I've shown throughout, the Board of Physicians has also promulgated sub-regulatory guidance, such as the FAQs. These are not the same as law, but they help with the interpretation that the board would take of the main bodies of law. So again, the main aspect, the standard of care in Maryland. So the same standard of care for telehealth services as an in-person visit. The laws regarding the confidentiality of health information is the same. So, HIPAA laws that would apply in Maryland, same laws that would apply for telehealth. The same standards evaluating, investigating regarding telehealth practitioners as patients that are seen in person. Also, it doesn't excuse a practitioner for failing to comply with requirements and ordering tests that would be required if they're not necessarily feasible via telehealth. This doesn't provide an excuse for the inability to order those required tests that would be needed to conduct the treatment in person. And so again, telehealth is just another modality of providing medicine. It doesn't allow you to excuse certain aspects that would necessarily be required in person. Instead, it's the same standard of care, but just a different way of providing that care. So here's Maryland's law on establishing the provider-patient relationship, and Maryland recently revised these laws. I think it was in early 2020. So previously, there was no ability to establish a practitioner-patient relationship via asynchronous telehealth. But because of the revised law, now a provider can establish a provider-patient relationship via synchronous telehealth interaction or an asynchronous telehealth interaction. So again, this adds towards the further ability for expanded equity to reach more people because it's not necessarily requiring that high level of broadband communication. The secondary modalities that are allowed to practice after that relationship has been formed, so include synchronous and asynchronous communications. However, this is an issue. There's a conflict between the statutes which were promulgated after Maryland's telehealth regulations. The regulations imposed a requirement that only synchronous telehealth could be used for establishing for providing telehealth services. Because there is this conflict, it's likely that the board will issue new regulations in response to the previously promulgated statute in order for these to be in accord. The Board of Physicians issued FAQs along the same lines that it recognized and acknowledged that there is a conflict in the laws between the statute that was promulgated after and the previously enacted telehealth regulations, and that this is upcoming, something that we will look for in the future so that this conflict will be resolved. But generally, for statutory interpretation, the telehealth laws would control over conflicting regulatory guidance. Statutes always control over regulations, so follow the statutes here in the case of a conflict. One issue that has come up a lot and I've discussed about access, and that's, can a provider treat a patient via telephone calls, emails, or faxes? The telehealth regulations do not apply to providing telehealth services via emails or fax. Those are not prohibited, however, but it's not considered telehealth. The board does not regulate reimbursement or provide advice on reimbursement, but instead it does note that the Telehealth Access Act of 2021 allows for audio-only conversations between a provider and patient for a limited amount of time, so for a temporary period during the PHE, ending on June 30th, 2023, which would allow for the audio-only telephone conversations for that limited period of time. However, after that time, telephone-only conversations would not be considered telehealth under the practice standards laws, which also, when we get to later on in the presentation, impacts the reimbursement of these services. Okay, the next section is on substance use disorder treatment and the intersection with telehealth and technology-enabled solutions to this issue. The U.S. is in the height of the opioid epidemic, as you all know, as frontline workers in this really ongoing, pervasive situation. This past year, the highest number of deaths were recorded due to overdoses. I was told that the group is already familiar with OUD treatment modalities and medication-assisted treatment being the primary one that is used, and telehealth can be used successfully as a tool to combat OUD. However, I also wanted to go over some of the barriers to providing substance use disorder treatment via telehealth, in particular OUD treatment. A practitioner has to untangle a complex web of federal and state law requirements, separate and apart from the various requirements that we just discussed as far as licensure and telehealth practice standards. I'll provide just a high-level review of these legal requirements that present a substantial barrier to entry for providers seeking to enter the SUD space, and also changes that we see ushered in by COVID, and then also things that we think are going to stick and things that we're hoping for in the future. So we'll start with federal regulations of MAT. So MAT, medication assisted treatment. The two main medications used in OUD MAT are methadone and buprenorphine, both of which are controlled substances under the Federal Controlled Substances Act. As such, prescribers must comply with the Federal Controlled Substances Act when prescribing buprenorphine for MAT or methadone for MAT. The Federal Controlled Substances Act, the CSA, requires all practitioners to prescribe controlled substances to register with the federal DEA in each state the practitioner prescribes controlled substances in. Practitioners who treat patients in multiple states must have a DEA registration in each state they plan to prescribe the controlled substances to patients in. So, for example, if a practitioner treats a patient with controlled substances in Florida and Georgia, the practitioner would need to be registered with DEA. They're personally registered with the DEA in both states, Florida and Georgia. Certain federal requirement or registration and licensure requirements also apply to providers seeking to treat patients with MAT beyond those applicable just to controlled substance prescribing generally. So, for example, another federal agency outside of DEA, SAMHSA, a branch of the U.S. Department of Health and Human Services, oversees addiction treatment programs in U.S. and operates the X waiver system and needed to prescribe buprenorphine in an office-based setting. Here's an overview of some of the changes in federal requirements for providing office-based opioid use disorder treatment services. So the key act in October 17th, 2000, Congress passed the Drug Addiction Treatment Act of 2000, the DATA 2000 Act, that amended the Federal Controlled Substances Act to establish waiver authority for physicians who dispense or prescribe certain narcotic drugs for MAT treatment or detoxification treatment. Under DATA 2000, qualified practitioners could apply for a waiver to prescribe or dispense buprenorphine for the treatment of OUD, and this is important, outside of a SAMHSA certified opioid treatment program or an OTP setting. Before this law passed, buprenorphine can only be prescribed, dispensed, or administered within an OTP methadone clinic. But because of DATA 2000, qualified practitioners could prescribe in an office setting. So this opened up access, the ability for more providers to provide this treatment, medication-assisted treatment to their patients without having to go through the various requirements of obtaining certification, licensure as an OTP, a methadone clinic. In 2016, the ability to obtain a DATA 2000 waiver was extended to qualifying nurse practitioners and physician assistants by the Comprehensive Addiction and Recovery Act, or CARA, the CARA Act, which again amended the Federal Controlled Substances Act. And practitioners at OBOTs can issue prescriptions, so now it's physicians, nurse practitioners, and physician assistants for buprenorphine that could be filled at any retail pharmacy, like other controlled substance prescriptions. And the Support Act further expanded the net of types of providers that could prescribe buprenorphine in an office-based setting. So different types of eligible nurse midwives, clinical nurse specialists, certified nurse anesthetists. The X waiver, as we mentioned earlier, is the DATA X waiver. To obtain a DATA X waiver, a practitioner is required to certify this following: that the practitioner has a current state license to prescribe controlled substances, a state DEA registration number, expertise, evidenced by certain certification, training, or experience, and the ability to refer patients to appropriate counseling and other services. So this is if you have the formal X waiver. The X waiver is still a limit. There's still limitations if you have the full X waiver. So practitioners are limited in the number of patients they may treat for OUD at any given time. As a baseline, during the first year of operating under your DATA 2000 waiver, a qualifying practitioner can only treat 30 patients at a time, but then may seek approval from SAMHSA to increase their patient limitation to 100 patients in their first year, and then up to 275 patients in a subsequent year. During the first year, if you're able to treat up to 100 patients using your X waiver, and you have the required training, you have to still meet two certifying conditions. One, the practitioner has to be a physician that holds a board certification in addiction medicine or addiction psychiatry by the American Board of Preventative Medicine or the American Board of Psychiatry and Neurology, or the practitioner provides MAT treatment in a qualified practice setting. So again, if you have these two qualifications in your first year, you can move from 30 patients to 100 patients and can prescribe buprenorphine up to 100 patients. After the practitioner's first year, so after the full year, operating under this 100 patient limit, if you qualify, then the qualified practitioner can apply to increase their patient limit to 275 patients if they submit a completed request for patient limit increase form and a statement certifying that they meet 8 certain requirements that are enumerated in the statute. So how does this information how does MAT treatment, how does this intersect with telemedicine? State telemedicine practice standards often include specific requirements for remote prescribing, and we mentioned that briefly when we went through the various telemedicine practice standards. These are based on the types of medication prescribed, so controlled substances or non-controlled substances. For controlled substances, we look to 2 sources of law. We look to federal law and state law. It's a little graphic, the federal plus state law equals controlled substance prescribing. Because controlled substances are regulated both on a state and a federal level. The DEA, again, is the primary agency that registers and regulates prescribing providers on the federal level, and many states have laws and regulations governing the prescribing of controlled substance. When we discuss controlled substance prescribing via telemedicine, the major federal legislation governing controlled substance prescribing is the Federal Ryan-Haight Act. Enacted over a decade ago, the Federal Ryan-Haight Online Pharmacy Consumer Protection Act of 2008 amended the Federal Controlled Substances Act and provided that a practitioner cannot issue a valid prescription for a controlled substance by means of the internet, including telemedicine technologies, without first conducting at least one in-person medical examination, except in certain enumerated circumstances. On March 16, 2020, the DEA published a COVID-19 information page that provided guidance relating to the federal public health emergency, including, importantly, the ability of a DEA-registered practitioner to prescribe controlled substances via telemedicine without having to first conduct a prior in-person exam. The public health emergency exemption is one of 7 exemptions to the Federal Ryan-Haight Act's requirement to conduct an in-person exam before prescribing controlled substances via telemedicine. So for the duration of the PHE, this waiver will be in place, and it allows a DEA-registered practitioner to issue a prescription for Schedule 2 through 5's controlled substance to patients without first having to conduct an in-person medical examination if 3 conditions are met. So the prescription must be issued for a legitimate medical purpose by a practitioner acting in his or her usual course of professional practice. The communication so that the modality must be audio, video, real-time, 2-way interactive communication system, so that's synchronous, gold standard, and the practitioner must act in accordance to federal and state law. So this last part is important, this last provision of the waiver. It requires compliance with both federal and state law. It's important because while federal law, this in-person requirement was waived under the Ryan-Haight Act for the PHE, states still may prohibit prescribing controlled substances under that state's telehealth practice standards. Under the Controlled Substances Act, in the event of a conflict between state and federal law, the more stringent standard will hold. So if a state does not allow prescribing of controlled substances via telemedicine without a prior in-person exam, that would be the standard that needs to be followed, even if federal law has waived that requirement for the duration of the PHE. So prescribing controlled substances via telehealth, some states allow it, some states don't, some states do with certain circumstances or for certain exceptions. So for instance, Florida allows you to prescribe controlled substances without a prior in-person exam, but only for certain treatments. So for 4 certain types of conditions, including if a patient has been diagnosed with a psychiatric disorder. Some states just completely prohibit the practice, while other states, again, they will allow it, but only for prescribing Schedule 2 or not Schedule 3, 4, 5, 6 controlled substances. So now with COVID-19, many states have also followed suit of the federal government and have waived these in-person controlled substance prescribing requirements. Notably, when states have waived these requirements for in-person prescribing, as with any other COVID issued waiver, and we must keep in mind that these are temporary waivers only, valid only for the limited duration of the emergency period. Each state has its own timeline, and even within a state, there are varying requirements. So, provider that wants to continue to treat patients and prescribe controlled substances that are located, not in geographic relation to them, even within Maryland, we must ensure that the waiver within Maryland, if there was one, is effective and that it would cover the ability, to this duration of time. Okay. And so another part of this federal prescribing is the DA registration, which was also waived partially for the controlled substance prescribing. So the ability to allow providers to prescribe in other states without obtaining full registration, which requires an in-person or physical requirement. And then finally, Matt, for telehealth modality, there was a waiver issued by DEA that allowed the treatment of Matt via phone call only, audio only, without having to meet the in-person, or I'm sorry, the face-to-face synchronous telehealth modality requirements. And so here's just language from the remote prescribing waiver from DA's website. So this was the very important bit of news that was released by DA. I know it's very unassuming, but this was really that sparked so much of the change of DA policy that really opened the gates up for the providers and their ability to prescribe controlled substances remotely. Then here's DA's prescribing guidelines, also issued on DA's website, and I have a link to it on the bottom of the screen. But essentially, it's a web to show which steps would be required based on the specific circumstances of that situation. And it's helpful for providers that want to determine if they're able to prescribe controlled substances or not, and which specific, which way to go on this web flow to determine what would be needed. And again, the DA registration waiver that was mentioned. So generally, DA requires prescribers to register with the state that they're prescribed, state DA in each state the patient is located in. So again, that originating state, and also the state that the provider is located in, or known as the distant site. But again, this was waived for the duration of the PHE. However, many states also have their own internal controlled substance registration. So for instance, Maryland has a CDS application that was not waived for the PHE. So if providers, out-of-state providers, wanted to prescribe controlled substances in Maryland during the PHE, although it would be waived on a federal level for DA registration, the provider would still need to register with the Maryland CDS. So again, main issues with COVID waivers, the duration, the limitations of scope, and if there's a conflict between state and federal law, we always need to abide and adhere to the more stringent law. And so, as we just mentioned, there's several barriers that stand in the way to providing treatment, and this lack of access is shown in the numbers. So while buprenorphine treatment is considered the best treatment for opioid use disorder, only 1 in 9 people with OUD have access to it. 40% of counties throughout the country do not even have one DA licensed buprenorphine prescriber, ex-waiver prescriber. And again, these are temporary waivers that we're operating under currently that is allowed for an expansion of treatment, but these are temporary waivers. We're continuing to wait on DEA to issue some sort of permanent guidance in order to ensure continuity of care for a lot of these most fragile patients that require ongoing maintenance through buprenorphine or other treatment. However, we're still in a state of flux and are constantly looking to DEA and the federal government to see how long these waivers will continue on until we have more finality. It's hard to plan for the future really on what the state of remote prescribing controlled substances will be. As far as permanent changes that COVID has ushered in, recently enacted, I guess it was a year ago now, but DHHS has issued guidelines for the administration of buprenorphine for treating OUD. So this guideline enabled physicians and other eligible providers to treat up to 30 patients with telehealth, 30 patients with buprenorphine without the need to go through the full notice process that we outlined earlier. So requesting to DEA that you have completed this training and you can verify you have certain education. Instead, any provider that meets one of these categories would be able to treat up to 30 patients with buprenorphine without going through that process. Excuse me for 1 second. DA also has issued a rule for NTPs, those are the OTPs, the methadone clinics, adding flexibility to the registration requirement if there's a mobile component. Recently, the omnibus spending bill was passed in March, allows for additional 5 months of telehealth flexibilities after the PHE ends, relating to Medicare telehealth reimbursement. While this was important to extend out for reimbursement purposes, this does not relate to the Ryan-Haight Act and remote prescribing waivers. So we're still looking to other sources of legislation to see what will change as far as a permanent matter after the PHE is expired. As far as state laws, we've seen several changes in state laws. These were often temporary waivers that legislators realized were actually very helpful, increased access, and they didn't see a lot of the issues that they were worried about when first deciding to issue these temporary waivers or not. So for instance, Ohio recently amended its telehealth law that allows MAT prescribing, expressly allows MAT prescribing controlled substances, which is a huge change. It was a very restrictive actually state medical board regulations before that. Florida recently enacted changes to remove restrictions on prescribing controlled substances without a prior in-person exam. Minnesota enacted changes to their Pharmacy Act that provide an express carve out for prescribing morphine and other drugs, controlled substances used in MAT. And then also Alaska removed a telepresenter requirement for a prior in-person exam when prescribing for MAT. Predictions, what do you think is going to happen when these COBRA waivers expire? As I noted, recent extension to the PHE, which adds these waivers for an additional 90 days. That was issued, I think, a day before it was set to expire. So April 13, 2022. Again, we're waiting on this long awaited DEA special registration that would create a permanent process for the ability of a prescriber to prescribe controlled substances without a prior in-person exam. And then again, we're waiting to see what's going to happen with the Ryan-Haight Act. Reimbursement issues. And I'm going to go through this rather quickly because it looks like we are nearing the Q&A section. I've gone a bit long. There's sources of payment. Obviously, reimbursement drives policy for many things. The provider is not going to offer a service if they can't be reimbursed for it. It's just kind of common sense. And so when we see states change their reimbursement policies, it's often because of a goal in hand. So we want to extend access, let's say, for telemental health. So usually one way to do that is by creating a more favorable reimbursement policy, either with Medicaid or with commercial payers, or loosening up their telehealth laws. But largely it's spurred by the sources of payment. As you can see, there's various ways that a provider is reimbursed for telehealth services or any other healthcare service. We'll start with commercial coverage, types of commercial payer statutes we usually see. So state laws will set forth these various requirements or will allow for reimbursement for commercial payers. So the Aetnas, the Cignas, what do they have to pay for? This is what these laws will prescribe. So commercial coverage, the type of private insurance coverage of telehealth services, varies by payer and by state due to these commercial payer statutes, which mandate private insurance payers to cover certain services, including services provided by telehealth. They often include certain characteristics in area coverage, including commercial coverage. Does the state have an insurance law at all that talks of telehealth? The next one, does the state say that the state needs to cover telehealth services as if they would cover an in-person service? And then payment parity, does the state reimburse telehealth services at the same amount as they would for analogous in-person service? So again, that first question, does the state have a law addressing whether they have to telehealth services in general, and does it allow that a commercial insurer has to cover that healthcare service that's delivered via telehealth at the same, so on par with any other coverage provided to an in-person consultation, for instance. So an example of coverage parity, let's say Dr. A has a participation agreement with a health plan that covers level 3 E&M services. The state has a telehealth coverage parity law. If Dr. A delivers that level 3 E&M service to a beneficiary via telehealth, that same level 3 E&M service provided via telehealth has to be covered as if that same service would have been provided in person, just as an example of what coverage parity looks like. Okay, so another example, let's say Dr. A's participation agreement with the health plan does not cover level 3 E&M service. In the same scenario, the state has enacted a telehealth coverage parity law. Dr. A delivers that level 3 E&M service to a beneficiary via telehealth, but because that service was not covered in person, it wasn't included as part of the participation agreement that Dr. A has with health plan. If Dr. A provides that service via telehealth or in person, there's no guarantee it will be covered. Again, it doesn't add a separate provision that requires coverage. Instead, it just makes it on par as if that service was provided in person. Then the next concept that we discussed was the reimbursement provision. So does the state need to reimburse for services provided via telehealth at the same rate as if that service was provided in person? So an example here, Dr. A's participation agreement with health plan reimburses Dr. A $50 for a level 3 E&M service. The state has enacted a payment parity law in this scenario. So how much will Dr. A be reimbursed for providing the level 2 E&M service in person? How much will they be reimbursed for providing that same service via telehealth? So under the state's telehealth payment parity law, health plan must reimburse Dr. A $50 whether she provides the level 3 E&M service in person or via telemedicine. Whenever Dr. A provides the level 3 E&M service, health plan must reimburse that same amount, $50. It cannot distinguish between paying $50 because that was provided in person or via telehealth. So this is a very important thing for coverage to ensure there's no discrimination as far as the service provided via telehealth or in person. For payment parity, we have to keep in mind that these are individual contracts. They're usually negotiated on a contract by contract basis and are subject to the participation agreement. So, if Dr. A negotiates a $50 reimbursement rate for a level 3 E&M service under his participation agreement with health plan, but another doctor, Dr. B, negotiates a $40 reimbursement rate for that same service, the telehealth payment parity law would not require the health plan to reimburse Dr. B for $50 for the level 3 E&M service, because the rates that Dr. B negotiated are only, that's only beholden to Dr. B. It doesn't impact the separately negotiated contract between another provider. It only requires the health plan to reimburse Dr. B at these rates if they're provided via telehealth or in person. So let's look at Maryland's law quickly. Commercial insurance law. So yes, the first question that we look at, Maryland has enacted a commercial insurance statute. Plans are required to provide coverage. So there's that coverage parity language for healthcare services if they're appropriately delivered via telemedicine. Plans are prohibited from excluding telehealth services from coverage just because they're delivered via telemedicine and not in person. So here's the language that provides in bold that coverage has to be on par with in-person service. And then there's specific language on behavioral health services that can be provided through a covered telehealth benefit. And separately, there's language that provides that coverage and telehealth has to include counseling and treatment for a SUD, so substance use disorder and mental health conditions. Lots of changes were enacted because of COVID with payment parity in various states, including in Maryland. So in Maryland, for this limited amount of time, July 1st to June 30th, 2023, when a healthcare service is appropriately provided through telehealth, an entity is required to reimburse the telehealth service on the same basis and at the same rates of coverage and reimbursement parity as if that service was provided in person. But there's certain exclusions to this. It doesn't include clinic facility fees unless the service is provided by a provider and is able to bill a separate professional fee from the healthcare service, or if there's any room and board fees. So the telehealth modalities that are reimbursable in Maryland, currently it's interactive audio, video, or other telecommunications or electronic technology. The definition of telehealth in the insurance code was amended temporarily. So again, from this PHE period to expressly include audio-only telephone conversations, but similar to the telehealth law that we discussed earlier in the presentation, neither the temporary or permanent insurance code definition of telehealth will include now or in the waiver period, email or fax. That's just excluded from coverage and is not considered telehealth. Also, other exclusions in Maryland's telehealth commercial coverage law. A plan is not required to reimburse a telehealth or a healthcare provider for a healthcare service that's delivered in person or telehealth if that service is not one that is generally covered under that health insurance policy or contract, and a health plan can impose a deductible, co-payment, or co-insurance either for the in-person or the telehealth service. A health plan can impose a maximum dollar amount as permitted under federal law, but a health plan cannot impose a lifetime dollar amount. So you can have an annual dollar max, but not a lifetime dollar max for the contract. Again, several states, including Maryland, have expanded their telehealth commercial payer statutes and provisions to allow for increased access. And we've seen that change into permanent law for several states. We'll see what Maryland does when this temporary provision expires and if audio only will be added on a full-time basis. So moving to Medicaid, another obviously major source of coverage. Two main areas, two main types of payment models for Medicaid. There's the fee-for-service and managed care. Managed care is really taking over. Over 68% of all Medicaid beneficiaries are enrolled in some sort of comprehensive managed care. Again, this has taken off since 2016. It was 65.5% in the US. Managed care, when the Medicaid agencies contract with a private Medicare organization, MCO, to deliver service via beneficiaries versus the more traditional fee-for-service model, where providers receive payment directly from the state for covered service directly to a beneficiary. And again, it's declining as states increasingly rely on a risk-based managed care contract arrangement. So states set out for managed care to be a set per member per month payment to the MCO for the Medicaid services specified in the MCO's contract with the state, often fixed upfront payment. So, capitation rate, managed care capitation rates are developed by the state and approved by CMS. So under the federal government contract with CMS. And then the regulations that provide this, 42 CFR Part 438. And just on a high level, Medicaid is a joint funded program between state and the federal government. There's lots of flexibility that states are given to administer their Medicaid program, subject to certain requirements, again, under the 42 CFR, 438. So a great deal of latitude on how to structure the program, including their telehealth benefit. And each state has such, they've set up their own regulatory framework for Medicaid telehealth reimbursement. And there's lots of differences between Medicaid telehealth reimbursement, challenges for providers, enrollment issues, and it's definitely more stringent, we've seen, than commercial payers. There's oftentimes an in-state requirement for the provider, and enrollment tends to be quite difficult from a state-to-state perspective. Quick glance at Medicaid in Maryland. Maryland Medicaid covers live video telehealth conducted by specific providers and in specific originating sites. So again, the patient has to be located in specific originating sites in order for that telehealth service to be reimbursable under Medicaid. In Maryland, recently passed legislation requires an expanded coverage. So asynchronous and RPM are also covered in Maryland Medicaid. And then the same until June 30th, 2028, requires coverage of audio-only telehealth and telehealth reimbursement policies. So similar to the commercial payer statute, this now expands to Medicaid coverage as well. Again, similar language that we described above, and here's the citation with the amended language. Telehealth does not include the provision of healthcare solely through, except as provided for this limited period of time, audio only telephone conversations, email messages, or facsimile transmissions. And moving on, a section of Medicaid telehealth coverage, Medicaid being the largest payer, limited coverage for traditional telehealth services under Medicare, and it's because it is a statutorily defined term under Section 1834M. For F of the Social Security Act. It sets certain requirements. Then on top of that, CMS issues each year a Medicare physician fee schedule on an annual basis that sets forth the conditions and limitations, what is covered, what is not. Okay, so reimbursement for telehealth services, this is the traditional understanding for Medicare. And again, this has been largely waived and changed dramatically with COVID. But generally, this was the limitation that a provider who wanted to treat a patient via telehealth only had to adhere to when seeking reimbursement for telehealth services under CMS for Medicare. So the patient had to be located in a qualifying rural area, originating site restriction. The patient had to be at one of 8 types of qualifying facilities. So again, that originating site. The service had to be provided by only one of 10 eligible types of professions. So this is a limitation on the type of distance site practitioner. The technology type was limited to interactive audio, video, telecommunication systems that permit a real-time communication. So this gold standard real-time audio visual was the only type of modality that was reimbursable. And finally, the service had to be among the list of CPT HCPCS codes that were considered to be covered under the telehealth benefit for Medicare. So again, these are these limiting conditions that provided a barrier for providing telehealth services to patients. The geography, so they can only be located in certain areas, the location where they're physically sitting at the time of the consultation, the type of provider, and then also the technology. There are exceptions to this, even pre-COVID framework, including the treatment of substance use disorder or co-occurring mental health disorder. So even prior to COVID, a patient's home could serve as a proper originating site, and there was no location. So the patient did not have to be located only in a rural area in order for this treatment to be reimbursable under Medicare. And I see that Robert has come on. I think that since we are running a bit late, maybe we should start the Q&A period.
Yeah, I was thinking it might be good because
Yeah.
people start dropping off, but Kelly Coble will coordinate the Q&A.
Great.
Thanks, Rob. We've mind melded, excuse me, turning our videos on. Sunny, this was so thorough and informative. We could have kept you here for 3 hours, perhaps. Maybe on another afternoon, we will do that.
Sounds good.
But we have had some questions, excuse me, come in. If folks have other questions, add them in the chat, and perhaps, Sunny, if we can't get to them in the next, chunk of time, we could send them to you.
Absolutely.
That would be great. There is one practical question, which is if we could get a copy of the slides or a link, so you can let us know if we're able to share this on our Telementalhealth website, a copy of the slides and the recording. That was a just logistical question that came in. I think everyone has found this really helpful. Okay, great. So that answers that question. We'll make that available. And then we'll start with some of the content questions that have come in. So a question that came in early on was, what if the patient's primary residence is Maryland, but the patient was out of state, say for a brief trip, and they needed to be seen for a visit during that time? Does that situation still require the other state's license for that visit?
Yes, that's a great question. We get that often. Yes. So again, licensure is dictated by the location of the patient at the time of the consultation. So even if the patient permanently resides in Maryland and is just out of time for a brief period of time, during that brief trip, if the patient is not located in Maryland, then the provider would need to be licensed in that state where the patient is located at the time of the consultation. So even for a brief, jaunt out of state, licensure is still triggered.
Okay. This is another location question. Can the practitioner be located out of the country when he delivers the service, as long as he's licensed in the state where the patient is? So this is about practitioner location.
Sure. So generally, distance site practitioner issues aren't as prevalent, except for reimbursement. So generally, there's no requirement in most states. There's a few, New Jersey being the exception, but outside of that, generally, it doesn't matter where the practitioner is located as far as licensing and telehealth practice standards. The issue comes in with reimbursement. So for Medicare is a no. You have to be located in the US in order to provide services that are reimbursable for Medicare. Medicaid, it depends on the state, but generally there's some sort of location requirement within the US. It just depends on the reimbursement source.
Okay, great. Thank you. This one is about Store and Forward. and you can let us know if you need more information on this, but this says, is store and forward only records sent by patient physician, or is a review of records in CRISP, so the Chesapeake Record Information Program, adequate?
Yeah, and I'm not familiar with CRIS offhand, but generally it's both. So long as the provider has some sort of clinically relevant extrinsic information that would be used when making that, normal in-person diagnosis, that's generally what we look to and when we see store and forward used. So states don't generally define what information has to be exchanged between the provider and patient. It's so long as the information would be relevant for making that diagnosis. If it was an in-person encounter, the same information would be used for store and forward, if that's helpful.
So you can let us know if you need more information on that question. Thank you, Sunny. Here's one about kind of maybe remote patient monitoring. So if we need to get vital signs such as blood pressure, especially when we're treating patients with certain medications, how do you meet that standard of care when providing telehealth?
Yeah, that's usually at the provider's discretion. So store and forward, if you have medical records that would be useful to gain that information, or you could have some sort of, blood pressure cuff is something that's generally used for RPM purposes in order to track the vital signs of that patient. It really depends. We see various ways, creative ways to generate that, patient data. Not as clear cut as what is needed in each particular situation, but I guess just what would you use if it was an in-person treatment of the patient? How can we try to as much make that work for a digital only setting? So yeah, again, I don't have a great answer there, but really what analogous technology would you use in person? And there, it's like a UX screen, something like that, then there are various ways that you can accomplish that. No great answer there, unfortunately.
I will say for that question specifically, Dave Flax is going to reach out. Dave and Gloria Reeves worked on an application, an FCC award, and we have some remote patient monitoring technology in the department. So I think Dave's going to reach out if you're interested in using that to do some patient monitoring of medications. So there, we might have some solutions if you're interested.
Yeah.
Here's another question, Sunny. Some licensing applications require a physical address within that jurisdiction to apply for a controlled substances license. This is the case for example, on the DC application. Is this an insurmountable barrier to prescribing in that jurisdiction, even if you're licensed to practice medicine in that location?
Yeah, and you hit on one of the major barriers that I know I breezed over it, but even though the DA registration requirement was waived, for the state by state requirement, states largely haven't waived their in-state controlled substance prescribing requirements. So there's no great solution. And that's something we're hoping we'll gain more information on when DA releases the special registration. We're hoping that the Ryan Haight Act special registration will include a provision that says if you're registered, with Ryan Haight, federally registered in this state, then you don't need to obtain a separate state controlled substance registration, something like that will provide some guidance. Our clients right now are dealing with the same issue. We're trying to figure out solutions. So one thing that we're recommending is partnering with an in-state physician practice and creating some sort of lease arrangement, space lease arrangement. And what we've done is created these types of partnerships. So if a DA agent, a state controlled substance registration agent comes for the investigation part, then somebody at least will be aware that this provider is using this address for purposes of registration with that state controlled substance office. And we've had different reactions. A lot of times that's sufficient. Sometimes it depends on the type of office that's being used. So it's not insurmountable for sure. There are solutions and ways around it, but there's just not a uniform solution that we've come up with yet.
So that's a good segue, Sunny, into the next question. And maybe you could take out your crystal ball for us. This question is about your thoughts about the Ryan Haight Act. Do you have thoughts about how maybe exceptions will progress, special registration, just generally, if you could look into the future for us, what you maybe think's coming?
Yeah, and something that we're tracking very closely. My hope and wish is that DEA will finally issue this special registration. And this is going to be so comprehensive that it's going to address all of these questions that we have, and also find a way to override state law that may be conflicting. So my hope is that DEA will finally issue the special registration, which will provide, it's an ability to prescribe controlled substances without that prior in-person exam. And then also will answer and address the issues on registration in state. That would be my number one hope. And I think there's something that's coming down the line. DEA is, we've maybe checked in with DEA agents once a month. The DEA office, various offices once a month or more have had conversations about this exact issue. So that's my number one hope, is that it'll be an all-encompassing, rubber band or like a rubber stamp that just says you're allowed to prescribe via telehealth so long as you complete this registration. Realistically, I think that there's going to be a carve out only for substance use disorder treatment. I think that's more politically expedient, and it's more aligned with a lot of the legislation we've seen that's been at least proposed recently. So I think that there will be a special registration process just for MAT providers. Maybe it will be tied in with the X waiver, I'm not sure. It will address a lot of the questions we have as far as MAT prescribers and their ability to prescribe controlled substances going forward, but it will still leave a lot of other types of treatment unanswered. But I think that's likely what will happen.
I think there are a lot of folks on the screen that are wondering and waiting. So I know everyone's waiting with bated breath. We appreciate you guessing for us. There is a last question here. I'll keep an eye if more come in. But another question about patients on vacation. If a patient is out of state on vacation and emails requesting a medication refill, perhaps that they've forgotten it and need a refill, can we confidently prescribe without actually having an appointment?
Generally, yes, if it's a refill. So a refill, if it's one that's provided for on like the face of the prescription and it's just a fill of that existing prescription, generally that's okay, and it's not considered a new prescription triggering the various laws for prescribing, safety license in the state the patient is located, et cetera, et cetera. If it is not, if it's one that is not refillable and it's considered a new prescription, then we have to go back and concede with the Hate Act. Are you licensed in that state the patient is located? Are you following, is remote prescribing of a controlled substance allowed in that state? So it really depends on the type of prescription you are filling. That's a general consideration. As far as the pharmacists, it depends. Most states allow a pharmacist to fill a prescription written by an out-of-state practitioner. However, some states do not allow that if the practitioner is not a physician. So if the practitioner is a nurse practitioner or a physician assistant, sometimes the state pharmacy board will not allow the pharmacist to fill that prescription issued by an out-of-state NPP or APP.
Thanks. Here is another DEA related question in Ryan Haight. It seems like the goal of the DEA is to prevent diversion. So they have no interest in removing obstacles like Ryan Haight. The leverage will have to come from Congress or the president. Do you agree with that?
So DEA is allowed to amend their regulations that interpreted Ryan Haight. I agree that DEA's focused, at least stated purpose, is diversion. And a lot of the ills that the Ryan Haight Act was originally promulgated to prevent, it doesn't really take into account our technology and the world that we live in today, especially with the ability to provide this important resource for substance use disorder treatment. So I think that it's twofold. I think that DEA and generally the legislators are very still concerned with the ongoing opioid epidemic, and they're worried. And part of the reason that Ryan Haight Act was initially promulgated was to prevent the proliferation of controlled substances. So there's this push and pull. I think that more education is needed for the legislators, and to show that buprenorphine Suboxone is not the type of drug that is commonly diverted and will lead to this ill that they're seeking to prevent. So I think it's definitely a gap in knowledge and understanding that more access doesn't mean diversion. More access means important treatment modalities and medications to patient. But again, there's, a lot of it's politics and a lot of it is just misunderstood. And so we'll see what happens in the future with, as far as buprenorphine and riot and hate act and treatment via telehealth.
Thanks. Here's an important question, I think, as we're all navigating, especially this public health emergency, and as you just were talking about access to care. Is there concern about retrospective legal action if a visit was conducted in a state where you did not have a license, or, for example, you called a person for a televisit and didn't expect them to be out of state on the day of the visit, but they really needed the check-in and you did the visit anyway?
Yeah, that's a great question. And it really depends. I think we mentioned that it's a holistic view of the telehealth encounter. So states generally, when they're taking, this will probably come from a medical board, right? If there's some sort of adverse action, unless a patient is injured, in which it would be litigation. I'm not a litigator, but I have litigated, and just litigation is the Wild West. So let's just push that aside, because anything, any claim can be brought, can be very spurious and easily put away and dismissed. But for state medical board actions, yes, you are, you're practicing without a license in that state. Technically, if you treated the patient, there was no waivers in place, and you provided some sort of interaction for the patient. But states, medical boards, they outweigh that ill with the care that you needed to provide to the patient. So it's not just a one view that you didn't have your license at the time. It's like, how expedient was this treatment? And if the benefits will outweigh the ills, then likely no action will be brought. So weighing it, seeing, technically you acted out of compliance, but was the necessity to act out of compliance overriding the patient's need for that treatment at the time? Don't make a habit of it, and I wouldn't recommend it, but sometimes it is necessary, and I think the boards will recognize that as well.
And this maybe is a good closing comment / question. Rob just chimed in. We spend a lot of time thinking about and worrying about the changing regulations and laws related to telemental health, but are you actually seeing charges being brought or providers being fined as we're navigating this? Is that happening frequently, or?
It's happening. I wouldn't say frequently, but yes. And it's really, I wouldn't say it's a more aggressive stance than outside of the PHE. I think that a lot of this comes from the floodgates were opened and providers rushed in. They saw the opportunity and they wanted to, provide treatment for more and more people without necessarily going through a telemedicine presentation that's 50 minutes long and understanding the ins and outs of what is needed and what is required. So I have, we have clients that provide OUD treatment, and we've seen board actions being brought against the providers for not acting in compliance with the state's laws and regulations, either not registering with the state's controlled substance registration, which we've seen actions brought because providers not obtaining proper state licensure. We haven't seen any actions with modalities. That seems like, unless it was very, very obvious, not standard of care, we haven't seen anything specifically addressing that. But there have been state boards that have taken, a more aggressive stance and are trying to go back and weed some of, the actions out. Again, it really was floodgates open. A lot of people ran in and they didn't take as many precautions as could have been taken when providing telehealth services in that state.
That's helpful, Sunny. We appreciate, we've taken you right to the last minute here. So really grateful for your time. Rob or Dr. Rockbeisel, I don't know if you have closing words, but I'm really grateful for all the information you've shared with us today.
And thank you again for having me. I can definitely make the slides available, and I'll send those over to you all after the presentation. And if you have any questions, and I'm sorry to get to finish the full presentation, but please let me know. I'm happy to make myself available.
Thank you, Sunny, especially for soldiering on in spite of not feeling so great, but it was a great presentation. Thanks.
Thank you. Thank you.
Wonderful. Thanks so much. Thanks everyone for sticking with us.